Welcome again, everyone. Our webinar for today is Improving EMS and Older Adult Caregiver Dementia Literacy to Improve Older Adult Emergency Medical Service Outcomes. Before we get started, I would like to go over some quick housekeeping items. All of you will be muted, but if you connect to audio using your computer speakers, that would be great. All attendees that have questions can use the Q&A feature. Key questions will be answered towards the end of the webinar. If you have any technical difficulties, email support@healthliteracysolutions.org for assistance, and I'll go ahead and place that on the chat box for your reference. And the webinar will be recorded and posted in the Health Literacy Solutions Center webinar archives. You will be receiving an email containing a link to a brief online evaluation. If you are requesting continuing education credits, you must submit that evaluation in order to receive your CE certificate. And with that, I would like to introduce our wonderful speakers for today. Like I said earlier, the title of this webinar is Improving EMS and Older Adult Caregiver Dementia Literacy to Improve Older Adult Emergency Medical Services Outcomes. And today we have Dr. Teresa Wagner, who's an assistant professor and clinical executive at UNT Health Science Center and Safe Care, Texas. Dr. Wagner holds a doctorate in public health. Dr. Wagner has delivered multiple programs, speaking engagements, and trainings on health literacy issues. Her research focuses on alleviating health disparities in underserved communities through health literacy to improve population health. Welcome, Teresa. We also have our wonderful speaker, Laura McIntyre, who's the Health Systems Director at Region 7 Texas Alzheimer's Association. She is a licensed clinical social worker with 20 years of experience working in health systems and nonprofit organizations. Currently, she is the Regional Director of Health Systems for the Alzheimer's Association, and she consults with systems to drive risk reduction, increase timely detection, and enhance quality of care for those impacted by Alzheimer's disease and related dementias. So with that, welcome. And I'll turn it over to you, Teresa. Thank you.
Thank you. Well, good morning or good afternoon, everyone. I'm excited to have this webinar with you today. And you can see here that this project was a collaboration between some very pertinent organizations enabled to be able to make everything happen the way that it happened. So these are the logos of those organizations, including academia, the Alzheimer's Association, and MedStar Mobile Healthcare. So our team included Daniel Ebbett, David Salguero, and David Dormady, who represented administration, the Mobile Integrative Health Unit, which goes to patients' homes to deliver care in home, and then also the 911 EMS system. Laura McIntyre and Audrey Quick from the Alzheimer's Association, Erin Carlson and her student Kayla DeMar from the University of Texas at Arlington, and myself from UNT-HSC and Safer Care, Texas. Our objectives today are to understand the role of health literacy in achieving the goal of the CDC and Alzheimer's Association Healthy Brain Initiative, to educate and empower the nation, and examine a novel training empowering first responders and in turn older adult caregivers with adequate dementia literacy to screen and refer to appropriate services. And then third, collaborate with EMS to integrate health literacy and dementia literacy principles in local and state EMS services to improve older adult EMS service outcomes. So first, we'll start with the background on this project and how we came about deciding what to do. So as you know, the CDC Healthy Brain Initiative is a partnership with the Alzheimer's Association, the National Institute on Aging, and the Administration on Aging, and on the national roadmap to maintaining cognitive health. Well, two of their top priority areas actually address health literacy, and those include disseminating the latest science to increase public understanding of cognitive health and to dispel common misconceptions. And then secondly, help people understand the connection between risk and protective factors and cognitive health. So when I first read those, I thought to myself, these are health literacy issues that are impacting or impeding care for brain health and potential dementia or Alzheimer's disease. And so it's important that people understand these concepts. So many people don't understand preventative services and or their insurance benefits and how to use preventive care benefits. Many people do not have adequate dementia literacy and health literacy skills to incorporate recommendations if they do seek preventive services. And additionally, preventive care should start early in life. We should be taking care of our bodies throughout life because we now know that risk factors for things like cardiovascular disease and diabetes actually play a role in brain health as well. So we should be incorporating health literacy health and wellness principles in K through 12. And then lastly, policy recommendations are lacking to ensure people receive health information they can understand and adhere to those recommendations. So CDC actually looks at health literacy in this regard is understanding and application of health information and services provided by health professionals. And it allows people to understand what they can do in health situations and when it is appropriate to seek emergency services. So we'll talk a little bit about how a lack of health literacy actually drives overuse of emergency services. So for those of you who don't have good background in the definition of dementia, it's a term for diseases and conditions characterized by a decline in memory, language, problem solving, other thinking skills that affect the ability to perform everyday activities. And many dementias are progressive, where symptoms worsen or slowly and gradually over time. So caregivers are people with dementia indicate that they have twice as many difficulties concerning emotional levels, financial security, and physical abilities. So what we know is that caregivers can also be impacted by providing care to people with dementia or Alzheimer's. Many people with dementia experience other chronic conditions that should be attended to on an ongoing basis. And so that's where the mobile integrated health services from MedStar comes in. And so they have these services that receive referrals from local hospitals and other healthcare services to help these people become more health literate and have more health self-efficacy at home. But they go to these homes of seniors with comorbidities and they help the caregivers as well. And so we thought of this as a way that they could actually educate the caregivers at the same time that they're providing care to the person living with dementia. So it provides these emergency service care providers with multiple challenges if they are called to the home in an emergent situation. So developing health literacy on both sides with the responder as well as the person with dementia and the caregiver could actually help to decrease any adverse outcomes that could come from that situation. So our work focused on abating and managing difficulty and raising public dementia awareness. So we wanted to incorporate health literacy tenets for access, understandability, and usability into the education that was available. So empowering caregivers, communities, and first responders with training, resources, and referral to Alzheimer's Association. So giving them a place that they could connect people rather than transporting them to local hospitals if it was ascertained that the situation really didn't require emergent service. It was more that there was a misunderstanding in what exactly was going on with the patient. So we developed a system for information and connecting them to resources, care consultation, referral to a primary care provider if needed, and thus reducing EMS usage and improving the care that our EMS providers could provide, knowing that they had a better understanding of dementia. So it would reduce unnecessary calls to 911 and identify ways to reduce inappropriate use with screening and empowering the community. So in order to do this, we actually incorporated a cognitive assessment screening tool into their EMR. So it helps them to have early detection of cognitive impairment, which is an important clinical and public health concern, because we know that if we get people into treatment earlier, that they have better outcomes. So we taught them to administer the screening, and in a quick way using the screening tool, so that it didn't take up too much of their 911 responder call time. And so the 88 or 8-item questionnaire was also utilized and helps them to ascertain whether or not there are these signs of cognitive decline. And I'm sorry that that's blurry. I didn't realize that. But you can look it up online. It's readily available. So the questions ask the respondents to rate changes that are identified, yes or no, in memory, problem-solving abilities, orientation, and daily activities. So you would likely give this to the caregiver to rate whether these signs and symptoms were indicated for that particular person that 911 was called for. So now I'm going to turn it over to Laura, who will educate you about the aims and methods of our study.
Thank you, Teresa. So really we had to ask ourselves several things on this project, right? We had to first figure out how do we better identify who these patients are, and really we used multiple categories for that. We had to think about the types of resources, the types of activities that we had to do, and then what outcomes we were looking for, right? Because there's going to be internal outcomes around the training and really advancing the staff's understanding around dementia and screening for it. And then what are those external outcomes, right? What are we trying to achieve? So really, as we thought about the resources that we had and kind of building the logic model, right? What kind of resources do we have to actually create the training, right? What did we need to develop? What resources did we have? What resources did Dr. Wagner have with her team? What other type of access do we have to the different people that we need to train? And then kind of ultimately, you know, what are those activities? And so initially, and we'll talk a little bit more about this, but we did a needs assessment. We had to kind of figure out where was the MedStar mobile healthcare team currently and where did we need to move them to? And then really, where is the 911 staff? How do we even access to them? And then what are the kind of ways to create and sustain kind of the awareness around it, right? Because we were working on not just an initial project, but actually this became year one of a multi-year project. So this is actually still ongoing. And so there was a year two, and now we're kind of into year three at this point to figure out like where do we need to go from here. So really thinking about how do we create a sustainable model, and then what are the outputs for that, right? How are we going to educate them? How are we going to evaluate those education? What are those resources and referrals? And then looking at those outcome measures and impact for that as well.
So our project aimed to develop health literate tools, materials, and dissemination plans, educate first responders about health literacy and dementia, refer caregivers to resources, and connect patients with providers for further evaluation. Our activities to accomplish our aims included providing and evaluating 5 in-person 1-hour trainings, including Alzheimer's and dementia, the 88 dementia screening interview, health literacy and communication with dementia patients, and creating and evaluating one online training for 911 EMS first responders, and then assessing MedStar referrals made to caregivers for dementia resources. And Laura, I'll turn it back to you.
All right, thank you. So again, initially we kind of created these open-ended interviews. So we developed some open-ended questionnaires, and we went in and we interviewed some identified staff to, again, really assess where is their baseline today, not just with the individual providers, but really where is MedStar, broadly, right? Because new staff are hired. And so we really assessed and thought about where are they today and where are we going to move them. And so themes sort of arose from that, pretty consistent themes. And they really informed the topics that we'd want to deliver, again, not for just this one project, but really ongoing. And out of that, we created these 3 different training topics and incorporated the health literacy skills in that. So in addition to our gathering information, we then circled back with Teresa and really kind of worked on what is the content that is needed. So next slide. So out of the training, really, we had to look at 2 different groups, right? We have this mobile integrated healthcare group, and think of them as kind of home health, EMS home health providers. And really that population is identified through MedStar for folks that call the 911 system frequently. And again, Teresa mentioned earlier, they're also referred externally, right? A system or a primary care practice, maybe they are calling the 911 system frequently. And so they're trying to identify ways to better manage care at home, keep these patients in the community as long as possible. And then the other group for MedStar are going to be the 911 providers, right? These are the actual paramedics, EMS providers that go into the home responding to 911 calls. And so these are 2 very different audiences, right? The MIH team is in the home often. They have a very large assessment tool that they use to kind of identify not just dementia, but all these comorbidities that often these patients have, whereas the 911 provider, right, may be in the home, certainly not often called because they have dementia. They called for other reasons, and they're more emergent. So as we looked at the trainings that delivered, right, and thinking about the mobile integrated health unit, we looked at that team and we provided these initial trainings. So the first one was to level set around understanding and approaching Alzheimer's and dementia. So making sure the entire team understood what it meant around dementia, because it's more than just forgetfulness, right? Decision making is impacted, ability to manage finances, ability to manage their own medication. So there's a lot of ways that Alzheimer's dementia impacts the patient and the caregiver, and then improving quality care. So helping them to better understand the dementia resources. And again, this is the staff. So in some ways it was around a train the trainer model so that they could convey some of this information in the home. So what are those resources? How do you do teach back, right? Really having Dr. Wagner kind of educate them on how to do teach back, how to provide this information well, and then difficult behaviors, because that would often be a reason to call 911, right? The dementia patient is showing behavioral symptoms, as sometimes they can do, and then helping them to better maybe manage those behaviors and not have to rely on a 911 system to intervene. And then the other thing that we added, and again, this was that actual systems change for the MIH team, was embedding the 88 tool, which indicates change. It certainly does not diagnose dementia, but it indicates change enough that it may require an additional referral or resources. So really educating that MIH team on what is the 88, how to use it, when to use it, and why to use it. And then there was a process. Should the patient not have a formal diagnosis and score a certain amount, then there was a system put in place to connect them to primary care to further that conversation. So that was the training for the MIH group. The training for the 911 team, they're very unique, right? These are not people that are often in an office, right? Because they're out in the community responding to 911. So the way that MedStar trains this team is a virtual training. So they put it up on Instagram and they put it up in other ways, and they're very short videos. And so this is a training model they do not just for dementia, but for a lot of things. It's a short video. This particular training was more of a conversation between one of our staff and kind of a question and answer. So it's a whole different way to train this team. And so those were the two types of training and the two types of audiences. Next slide. And so in that, the different topics, again, was really looking at intro to Alzheimer's, the dementia caregiver training as well, because as Teresa mentioned earlier, this is a key component. This isn't just about intervening with the patients. Very often the person that you're going to work with or even advise is going to be the caregiver, not necessarily the identified patient. And the other thing to consider is the MIH patient may actually be a caregiver of a loved one with dementia, right? But they're managing their own comorbidities and then trying to care for their loved one. So really training kind of holistically around the patient and the caregiver. Again, communication strategies, really key in when you're working with dementia patients and their caregivers. So some key tips, again, that teach back and the use of the 88. And then for the 911 team, really understanding and recognizing Alzheimer's, just so because there's a tool that we embedded, they had a better idea if they're seeing indicators in the home, some things they can do to better identify these patients so that we could then think through the next step strategies of what to do with those patients without a diagnosis, showing signs of dementia, and often calling the 911 system. And so how did we evaluate this training? We used post surveys and evaluated attendees' perceived effectiveness of the training. So could they have put it into practice in their real world? Did they have satisfaction with the content and delivery? And I was one of the persons delivering it, so I always want to know if we delivered the content well. And then did they increase their knowledge, right? Did they actually, and so there were some questions around, did they increase their understanding? And then fact-based questions, right, around kind of that training content. And then the post surveys, right? We gave them immediately after the training, both in paper because they were in person, and then some online evaluations. Sometimes they have their phone in their hand and it's just easier for them. So bringing both of those evaluations usually gets more response for us. The questions varied, right? Some were true, false, some were multiple choice, and some used a Likert scale for us. They were very short evaluation. And then we had a cumulative survey that was at the very end, so actually several months after. So we looked at kind of the overall program and evaluated that as well. So it was, I think, 3 or 4 months after some of the training and the other things that we implemented. So this is showing you, and again, this was kind of a key component because one of the questions we ask ourselves as a team is, how do we figure out for folks that actually call 911 who has dementia? So there's several different ways that we had to discern that. So one of the ways is that we actually began to embed questions in the EMR. So as the 911 provider, and so this is different than the MIH team, but as the 911 provider entered the home and they have many questions embedded in their electronic medical record, and it's administered through basically an iPad type system that the provider has in their hand. So the first question for us is, did they know if they had a formal diagnosis, right? And that was an easy answer. If they were like, yes, or the caregiver said yes, a doctor has told us that they have dementia, that was a simple yes. So that was one indicator if the patient calling the 911 system had that actual diagnosis or had been told that. But then what happens if they answered no? Right? And that got us to the next 3 questions. And the other criteria is this particular button, as they call it at MedStar, only populated if they were over the age of 65. So we didn't want to have to ask this question of every person that called the 911 system. That would have been too many. So there was a criteria that this particular button did not even appear unless they were over the age of 65. And that is because our REIS increases as we get older, and 65 is kind of a good demarcation of that. So then the next questions were, and again, this is not diagnostic in any form or fashion, but what could be some indicators? So we asked some additional questions, right? Did the caregiver, right, actually notice signs of memory and thinking? And we tried to create these questions in more of a health literate way, so they were simplified. So, ask the caregiver, are you seeing these signs of memory? And then because we had trained these 911 providers, are they seeing signs? They understand more of what to look for. They've said no, but as I'm in the home and some things are happening, for example, they keep repeating themselves. They seem more confused, more than normal. Does the 911 provider think that there's something not quite right, and they could indicate an answer of yes? And again, these are not going to be diagnostic criteria, but indicators that something in that memory and thinking has been affected that we could use later. Again, this was to create kind of that initial data collection to figure out how many folks are calling 911 of these older adults that are showing signs and symptoms, because that helped us to determine additional follow-up of what additional projects we could do. So next slide. So what were these methods for referral and practice change? So we looked at kind of this education and potential quality improvement projects, not only for today, but in the future. And so this happened, interestingly enough, right at the beginning of COVID. So it actually impacted our data, and I'll talk a little bit more about that, because one of the things that happened during COVID is people stopped calling the 911 system. They actually had a lower call rate, which is not typical for MedStar during this particular season because of COVID. So this, I believe the evaluation was in April and March at the very beginning of COVID. So we know that it impacted the data in several ways, but we did assess over a 2-month period. So we turned the button on and we wanted to look at, what happened during that 2-month period. And again, it would inform kind of future projects and future opportunities. The other thing that we really looked at and kind of, what do we do with these patients, right? We don't just want to identify them, we want to connect them to resources. And so we looked at the in-home visits and actually created we had done this previously, but it really actually increased the referrals to us if they were showing signs and symptoms, to answer questions, or they had a formal diagnosis. That may have also increased actually MIH going into the home. Right? If someone showing signs and symptoms is calling 911 a lot, maybe that's a good person to refer to the MIH team. And then really embedding an actual practice change. So prior to this project, they were not screening for dementia. They weren't really looking at that and didn't have a standard protocol to get them into primary care to assess, because there's other reasons why memory and thinking is affected. And so again, primary care is the next step. But seeing those indicators and creating a robust referral system was important. And then the last thing is another project was happening in parallel to our project, where they are creating a detect tool around abuse and neglect for older adults. And they were using that SMOCA that Teresa mentioned earlier. But one of the things that was happening as a part of the detect program is, if you had a sign or symptom of dementia through the SMOCA, you were actually not able to participate and detect. But then what do we do with those patients, right? And so another practice change was created that if they had indicators and showing signs and symptoms of dementia, they were also referred to us so we could connect them with resources to figure out what was going on for that patient. Next slide. And so looking at the data, right, there were some other indicators. So as I mentioned earlier, with the buttons that we had in the EMR, we were trying to identify patients that actually didn't have some of those indicators of dementia, but we needed to capture them in other ways. So they created some other ways to pull data out of their EMR. And so in the narrative itself, if words like dementia or demented or Alzheimer's or Alzheimer were in the narrative, that was a way to pull out and kind of identify those patients. In the patient history criteria, did they actually have a documented formal diagnosis? Alzheimer's disease, such as frontal temporal, Alzheimer's disease, unspecified dementia. So we actually looked at some of the coding, and that was another way to pull kind of whether or not the patient that was calling 911 had dementia. We looked at location. So for example, if it was a car wreck on the side of the road, there were some things that eliminated, but we did look at most of the locations they called from. Differential diagnosis, we also use that as criteria. And another indicator that is an excellent indicator of dementia is, were they on typical dementia medications? And interestingly enough, it is not unusual that a patient may actually have prescribed dementia medications and not have a formal diagnosis. So it is a great indicator. So that was another way that we could pull, and we're going to look at some of the data comparing kind of the buttons and indicating through that, EMR questionnaire versus an actual kind of more formal indicator. Next slide. And so looking at that, right, some of the methods of how we looked at that, so we looked at the number of the 911 employees and those survey forms, looking at the practice change. Again, we've mentioned that earlier in the tool. Again, to use the EMR indicator, they did need to be over the age of 65. The button didn't appear without it, and we assessed it over a 3-month period. And then looking at that call year over year, again, looking at that, assessing whether there was an uptick in dementia calls compared to the prior year, which again is interesting because the 911 calls as a whole went down. So that was an interesting thing to kind of look at. And we tried to compare, right, the 2019 to the 2020. So in 2019, right, of the total that called, there were kind of this 252 indicators, but that only would have been some of those indicators I mentioned earlier that they were on dementia medications, or there was Alzheimer's in the notes because we didn't have the EMR assessment tool. And then the results in 2020, there was actually an uptick of those dementia indicators, yet less called 911. So you would see actually the percentage itself actually incrementally increased. And so what were the results from what we learned? So the training results, right? The good news is we had a lot of that training completed. So we got a pretty high response rate to the actual training itself and the surveys. So that is always good news for us. Next slide. And then these are some of the indicators, right, that we got either agree or strongly agree. So they were able to apply it to what they learned. They would recommend the training to others. So that was really a good indicator for us that this is the type of training we needed to continue to do within MedStar. And they improved their, ways to not only work with the patients, but caregivers as well. So it told us this is the right kind of training that we should continue to do within the MedStar team. And then looking at the other education, kind of that first survey, and this is a different training that we did, right? That again, they were able to all respond to this. I believe this is actually the 88 training, which is even a smaller group and even probably more interactive because they had some activities. So everyone was able to do that. And again, looking at this, agree or strongly agree, those are always good indicators that the training was in the right way. They'd recommend it to a colleague and it is increased their understanding. So always good indicators when we get that agree and strongly agree that this is the right kind of training and we delivered it well. And then, oh, this is the 88. Again, it was small group trainings because it was more interactive. They actually were given not only training on the 88 tool, but they are actually given case studies that we wanted them to score. So it helped us to know, even in their scoring, that they were on target and could use the tool well. So again, completed all of that. And then the 88 training had a little bit different metrics that we were measuring. So they did learn the signs of dementia. They did understand how to administer the tool itself. They understood how the scoring actually differentiates. Again, a score of over 2 indicates change in memory and thinking. They felt like they could apply it to their work and they would recommend it to others. So again, an indicator we were on target with training, and we will continue to use that. Now, the one that was the greatest struggle was the 911 video training. Again, the training went out right as COVID started, and I have a suspicion they had a lot of other trainings going on because we were so early in COVID at that point. I mean, I assume they were trying to figure out when they were calling 911 and going in, you called for a heart attack, but you also have COVID, right? So there was a lot going on during this particular season. And I believe we maybe even pulled the video at one point earlier because there was so much competing priorities that were very, very important to the 911 team. And so very few actually, viewed the video. They had increased workload, and we just didn't have enough data to even assess that this is the right kind of training. And we will likely revisit this going forward because there's new projects that we're going to start with them. So this is the one that didn't work out quite as well for us. And then the results, right? So this is super interesting, as you think about how COVID. So again, in 2019, a lot more folks that were older called the 911 system in this 3-month time period than they did in 2020 during COVID. So that alone impacted even some of the results that we would have seen. And so the indicators of using the screening tool, that about 250 folks actually showed signs and symptoms, but 343 actually had more of that dementia criteria, right? Looking at the medication, whether there was dementia in their narrative. So it's very interesting to think about those that responded to the questionnaire versus that. And we only had about 98 folks that actually matched, right? Had dementia in their, indicators and more diagnostic criteria versus responding. So there's really a disconnect between patients that have dementia versus those that can actually report they have dementia or have those signs and symptoms. And we knew that because patients are very often underdiagnosed, diagnosed quite late in the disease. And that's another part of my role, is really working with primary care to better diagnose these patients. And as I mentioned earlier, they can be on dementia medications and not actually have a formal diagnosis or realize they have dementia. So these are things that we continue to look at. Next slide. And then the tech study, as I mentioned earlier, we saw a tremendous increase in getting these patients. So many were screened using the SMOCA. Quite a few did not pass the hearing screening, so that was a first indicator because they couldn't hear well. They couldn't participate in the DETECT study. And then several started the MOCA and didn't finish it, which is not uncommon. Sometimes that's because they're showing signs and symptoms and they don't want to complete that, but there are other reasons. But several actually completed, but as you can see, 373 actually completed the assessment and only 258 passed, meaning they did not have signs and symptoms, and they could then participate in the DETECT study. But that meant that several were showing signs and symptoms. So about 115 people were showing signs and symptoms of dementia and may very well need further assessment and screening, but only 26 agreed to be referred to us so we could further the conversation. And again, those referral conversations would include things like, you've shown signs and symptoms, we'd like to connect you with primary care to further that conversation, Again, it's not an indicator, but it's showing signs and symptoms. So not very many were even willing to talk to us to get connected with other resources, but it shows that quite a few in this study were showing signs and symptoms that probably should be having conversations with their primary care doctors. Next slide. And so the result of the 88, it did increase, again, 500%. Adding the 88 increased referrals to us. So again, they had signs and symptoms. So part of that referral was not only connecting with primary care, but giving them access to our other resources such as support group, education, helping them to learn more about the dementia and for the caregivers and for the patients. So we were very grateful for this systems change to get them connected to more resources. And then that result summary, as we said, dementia caregivers were trained on the resources. So we know we connected with more resources, which was one of the goals of this project. We know that the team better understood not only the signs and symptoms, but better ways to identify these patients and work with the caregivers. So we know that this was a great project, very successful, and opened doors to additional work we could do with them, and we still are doing with them. And with that, Teresa, I'm going to hand it back to you.
So as with any study, there were some limitations and future directions that we took from the study. And so the limitations were that EMS providers have heavy demands on time limits and thus the potential for training. So it was very difficult to get onto their schedules. And as you saw, very difficult for the actual 911 crews to be able to take the training, especially in the time of a pandemic. There also was some limitation in the capacity of the MIH team and the Alzheimer's Association to actually act on any screenings that were sent their way, because if you're used to a certain amount of referrals and then all of a sudden there's a huge uptick, it takes a while for you to staff up or to increase, the time that you allow in that particular work in order to take on the capacity of all of those additional screenings that are sent your way. So we needed, and in the future also need to identify alternative and additional sources of assistance so that if that capacity of the MIH team and the Alzheimer's Association becomes overwhelmed, what are some other places that those referrals can be sent to still get intervention despite this lack of capacity. So in the future, we want to assimilate the 911 data for future practice and systems change. So we're hopeful that now that the pandemic has abated to some extent, that we will be able to pick this up and continue assisting the 911 crews with changes in their system to help with referrals. Disseminate the developed tools, processes, and resources throughout systems. So our hope is that this will be adopted throughout the country in EMS systems. We've published in EMS World, a trade publication for EMS providers, this study as a best practice. And we hope to have more opportunities for dissemination, education, and training with the EMS and communities. Conclusions and implications for practice include that EMS providers are receptive to trainings to identify dementia, communicate with dementia patients, and refer caregivers to services. So the trainings offer effective health literacy learnings and dementia learnings as well for EMS providers, that they reported satisfaction with trainings about dementia. Secondly, there are thousands of calls in an urban catchment around dementia issues. And so thus there's ample opportunity to practice training content and employ local resources to support and inform caregivers. And we know that that will only grow in the future as more of, or a larger percentage of our population becomes over the age of 65. And then embedding screening into the EMR actually offers a fail-safe to identify additional services and support for patients, EMS providers, and the community. Our logic model outcomes are that we improved and created sustainable EMS health system strategies to reduce community-wide deficits in knowledge regarding dementia, thus addressing dementia literacy. We developed knowledge and robust collection of community resources to refer people directly to community partners for related services and resources, and thus improving access to care. And these activities increase the percentage of patients, regardless of age, with a diagnosis of dementia whose caregivers were provided with education on dementia disease management and health behavior changes, and referred to additional resources for support within a 12-month period. And that's actually one of the outcomes that's specified by the Healthy Brain Initiative. These are the references that we used in our background. And we will now open for any questions that you might have. So I don't see anything in the chat, and I answered one that came up in the Q&A, but you're welcome to put any additional in the chat if you'd like. And otherwise, I think our contact information will be available with the recording on IHA's Solutions Center moving forward. Thank you. Thanks, Russ. Yeah, it was really rewarding work.
I agree. I agree. And I want to say just briefly, as you think about like, where do we go with this? So one of the reasons why this project was so key is that we know that the 911 system, that is who transports to all of our local hospitals. And so that's one of the goals next time, is to figure out, okay, who are these patients that actually have dementia? Because once they end up in the emergency department, right, which is often their solution to healthcare, right, and not really the best solution for them, what happens on the back end of the emergency department, right? How can we then better identify these patients and then better serve them in the emergency department and better equip the hospitals and the systems themselves to receive these patients? So.
All right. Well, thank you, everyone. We've enjoyed presenting to you. And again, feel free to reach out if you have further questions or would like kind of our blueprint to approach your own emergency medical system.
Thank you again, both, for a great presentation. It was a pleasure to have you with us. And for attendees, if you don't have any questions, you will receive an email containing a link to a brief online evaluation. If you are requesting continuing education CE credits, you must submit this evaluation in order for you to receive your CE certificate. So this concludes the webinar. Thank you all for attending. We hope you have learned a lot and enjoyed this presentation. And again, thank you to our wonderful speakers.